All right, so today we'll be discussing the Michelin and Collins article. All right, so first, the participants. First, we have Coleman, who was a 22-year-old male who was diagnosed with a moderate intellectual disability, according to the Kaufman Breach Intelligence Test. Coleman could communicate in complete sentences, although he frequently replied with 1 to 2 word responses. He was more expressive when interacting with peers and when describing his favorite activities such as dancing. He was able to read and follow a daily agenda. He could write legibly and complete basic information on job applications. He needed to increase his ability to write in small spaces and write his name in cursive. So some of his life skills that he could do, he was able to shop from a written list with assistance for less familiar items. He recognized coins and could count different combinations except quarters plus dimes. He was able to read a calendar for information and use personal calendars for time management. He rode the city bus and could locate 3 stops independently, and he was independent in caring for his personal needs. Second, we have Lionel, who is a 20-year-old male also diagnosed with a moderate intellectual disability. His IQ scores were unattainable on the Stanford Intelligence Test. At the age of 5, he attained an age equivalent score of 13 months on the Bayley Scale of Infant Development Test. His adaptive behavior composite score was a 55 on the Villon Adaptive Behavior Scales. So when spoken to, Lionel would use single word and word approximations to communicate. He often said, "I don't know," in response to questions. He was reported to be very quiet and did not initiate telling peoples of his needs. He also used pictures to facilitate his expressive communication. He rarely made eye contact and frequently closed his eyes when spoken to or presented with a request. He used a picture list to go shopping. He can also identify 26 community signs and point to the information on his identification card when asked his name, address, and phone number. Okay. So third, we have Neville. He was a 21-year-old male diagnosed also with a moderate intellectual disability. Neville communicated with 1 word and short phrases in both Spanish and English. He had a diagnosis of dysfluency. His English was better understood in context and by those familiar with him. He became easily irritated when other students touched him or looked at him. His needs included increasing his recognition of functional words and signs in the community. He could trace letters and circle pictures to indicate answers on a page, but was unable to write independently. He could rote count up to 10, but did not recognize numerals. So he could count, for example, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, but he didn't have no idea exactly what the numbers looked like. He enjoyed cleaning and volunteered to assist with such tasks in his classroom. He was able to care for his dressing needs as well. Some more of his needs further included crossing the street safely, entering and exiting the city bus, locating items on the shelf when directed to the correct aisle, and paying for purchases using a large bill. So he also needs help in those areas as well. And then fourth, we have Wanda, who was a 19-year-old female diagnosed with a moderate intellectual disability. Her IQ was a score of 44, according to the Stanford Intelligence Scales test. All right. And her adaptive behavior score was a 58, according to the Villon Adaptive Behavior Scales. Wanda was able to communicate in complete sentences and use slang and current vocabulary used by her peers. She was able to read sight words and community signs and words and use text functionally. She could tell time on the hour and half hour and could use the skill for time management. For example, as arriving at a destination at a specific time. Wanda was working to improve daily living skills such as her ability to independently cross the street with traffic lights and counting coin and dollar combinations to $20 and identifying the amount of a purchase by looking at the monitor on the register. She was able to care for all her personal care needs and enjoyed shopping for clothing. Her needs included sorting and independently washing and drying clothes. She could follow simple recipes with pictures and words using a microwave stove and an oven. Her needs were she struggled with the ability to plan and prepare meals. Okay, and so just a few questions that arose from this study. Basically, when looking at the four participants in this study, they were all between the age of 19 to 22. So that that the fact that that age range, could the results vary if the age range was younger, and also the fact that all four participants had the same disability, which was a moderate intellectual disability. How would the results vary if the disability was different? All right.
Hi, this is my part of the Group 2 presentation, and we're going to discuss the design of the article. The study used an adapted alternating treatments design with baseline comparison and final treatment conditions to compare the effects of video modeling with and without verbal cueing on the completion of fine motor cooking related tasks for 4 students. Now, with the dependent variable was the percentage of cooking-related tasks completed independently. The 2 treatments were applied to functionally independent tasks. Steps completed independently equated to response difficulty. Now, the experimental conditions include a baseline with a verbal task directions such as cut the celery. Initiate each task after being given for each of the 3 sets. Followed receiving video modeling with the verbal and without verbal cueing and continuation of the control set task. Incorrect performance or comparison condition. A final treatment condition was then applied to the control set, followed by a final best treatment condition in which the superior treatment, the video modeling with verbal cues, was applied to the task which did not receive verbal cueing during the comparison condition. Now, for your procedures, the sessions were conducted individually across all conditions and video models. With and without verbal cues were counterbalanced across tasks and students to control for task difficulty. The 2 sets of tasks were counterbalanced across 2 pairs of 2 students moderately intellectually disability, so that one set was presented with 1 pair of students using video models with verbal cues, and the second pair to students using video models without verbal cues, and then of course vice versa for set 2. Counterbalancing the interventions within sessions was used to minimize the possibility of sequencing effects. So to continue, the baseline conditions serve to demonstrate student performance on the 15 task items without video modeling and the equivalence of performance on the 2 sets. Inclusion of the control set is intermittent measurement during the comparison condition, and the final treatment condition were included to assess possible multiple treatment interference. That's your threat to the internal validity, the effects of history and maturation, and to provide intra-subject replication. The final best treatment conditions serve to detect multi-treatment effects by evaluating the best treatment or video modeling with verbal cues in isolation and determine if prompting the superior treatment, the alternative set with the video modeling with no verbal cues, would produce any change in performance.
Hi, I am Grayson Mitchell, and I'm here to talk about my part of the article that my group is presenting this week. So, the dependent measures for this study. So the dependent variable measured in the study is the percentage of cooking-related tasks completed independently by the students. And each student was evaluated on 15 fine motor cooking relating skills to determine the percentage that they could complete independently. For the reliability of procedures, which is the fidelity and the measurement of the inter-observer agreement. So during the study, the first author conducted all baseline and video modeling sessions, and the second author collected reliability data. The reliability data on the dependent measure was collected on 33% of all baseline video modeling comparison, final treatment, and best treatment sessions. The inter-observer agreement was calculated by dividing the number of agreements on each step by the number of agreements plus disagreements and multiplying by 100. The mean inter-observer agreement across all sessions was 98.9%. So their inter-observer agreement was very good. Talking about the results, overall, the combined scores across the 4 participants showed a difference in performance in favor of video modeling, with verbal cues with a mean of 72.8% correct with the verbal cues, and a mean of 61.8% correct without verbal cues. To go a little deeper into that and look at a visual analysis, so baseline data for each student remained low across the 3 sets of tasks prior to the comparison condition. When video modeling with and without verbal cues was introduced in the comparison phase, Wanda and Coleman's performance improved considerably when using video models with verbal cues. Their performance also showed improvement when using video models without verbal cues, although the level of change was not as abrupt. Overall, Wanda's mean performance was 91.8% correct when using video modeling with verbal cueing and 15.4% correct without verbal cueing. Coleman's mean performance was 98.3% when using video modeling with verbal cueing and 71.3% without verbal cueing. And to continue this, although Lionel and Neville showed improved performance with the introduction of video modeling, the change was not as abrupt, and each experienced a gradual change in his level of performance. So overall, Lionel's mean performance when using video modeling and verbal cueing was 52.7% correct and 46.4% correct when using video modeling without the verbal cueing. And Neville was the only participant whose performance was greater when using video modeling without verbal cueing, which was 48.6%, compared to video modeling with verbal cueing, which was 32.6%. And here are the graphs that were used to show the improvement of the participants. So overall, this did seem to be an effective way to teach students how to do these fine motor kitchen-related